Hey, pediatric crew, let's catch our breath. Welcome to the deep dive. Today, we're diving deep into the incredibly important and sometimes pretty challenging world of pediatric respiratory conditions. We're pulling all our insights straight from the source, pediatric respiratory disorders and care.
That's right. Our goal today is really to unpack what makes breathing problems in kids so, well, unique. We want to help you sharpen your skills in recognizing those crucial signs of trouble, understand some key interventions, and, maybe most importantly, know what information empowers caregivers the most.
Yeah, think of this as a focused look at the essentials, kind of a shortcut to feeling really well informed on this topic.
Exactly.
So we're going to start with the very basics. What makes a child's airway different from an adult's? It seems fundamental.
Oh, absolutely.
Then we'll build on that, covering how to assess them, what tools help us figure things out.
Yeah, the diagnostics.
Right. And then zeroed in on some of the most common and most critical upper and lower airway conditions you'll encounter, both the infections and the non-infectious stuff, too.
And we'll touch on a few other related topics before we wrap things up. It's quite a bit of ground to cover, but we'll definitely highlight the key takeaways.
Okay, let's unpack this. Everyone says kids aren't just small adults, and nowhere is that clearer than their respiratory system. Why are their airways so fundamentally different? What does that mean clinically?
It's truly foundational. Their anatomy and physiology just create a completely different landscape for breathing. The upper airway, for instance, is proportionally much shorter and narrower.
How much narrower are we talking?
Well, think about this. A newborn's airway is about 4 millimeters in diameter, and adults, around 20 millimeters.
4 millimeters. Wow, it's incredibly small.
It is, and here's where it gets critical. Just 1 millimeter of swelling, say, from inflammation or mucus, can cut that tiny 4 millimeter airway diameter by half, 50%.
50% from just 1 millimeter.
Exactly. In an adult, that same 1 millimeter of swelling reduces their 20 millimeter airway by maybe 20%. So you see, minimal changes have huge impacts on airflow in a child.
Wow, okay. So a little bit of inflammation is just a massive problem for them.
Precisely. Another crucial difference. Newborns are obligate nose breathers.
Meaning they have to breathe through their nose.
Right, until they're roughly 4 weeks old. If their nose gets blocked, they don't automatically switch to mouth breathing like older kids or adults do.
Which explains why a simple stuffy nose in a tiny baby can be much more concerning.
Exactly. And there's more. Their cartilage in the larynx and trachea, it's more flexible, floppier.
Okay.
This makes it more prone to collapse if their head isn't positioned right, or it can easily spasm if it gets irritated.
Makes sense.
And their intercostal muscles, the ones between the ribs, they aren't fully developed until around age 6.
Which is why you see that belly breathing in little kids.
Right, that abdominal breathing pattern is totally normal for them. It's not a sign of distress unless it becomes paradoxical, seesaw breathing. Plus, they have a higher metabolic rate. This means a higher demand for oxygen. We're talking 4 to 8 liters per minute for a newborn compared to maybe 3 to 4 for an adult.
So they just burn through oxygen faster.
Which drives their faster and often kind of irregular respiratory rates. Also, their airway smooth muscle isn't fully developed until about 5 months old. Meaning they lack that immediate bronchospasm response, that tightening of the airways as a protective mechanism early on.
So they're less able to clamp down those small airways to protect themselves.
Correct. And they start out with far fewer alveoli, the tiny air sacs for gas exchange, about 25 million at birth, way less than in adulthood.
So less surface area for oxygen to get in.
Initially, yes. The source also points out the angle of the right bronchus. It's steeper in kids.
Oh, right. Making it a more common spot for inhaled foreign objects.
That's the clinical takeaway, yeah. Things tend to go down that right side more easily.
Okay, good practical point.
And don't forget, larger tonsils and lymphoid tissue potentially blocking the upper airway, and those shorter, more horizontal eustachian tubes connecting to the ears.
Linking to all those ear infections.
Exactly. So all these anatomical and physiological differences really underscore why pediatric respiratory assessment and care need a very specific approach.
Okay, here's where it gets really interesting, I think. Given those unique airways that can narrow so easily, how do you actually tell if a child is having trouble breathing?
Yeah.
What are you scanning for in those first few seconds?
Well, assessment starts even before you lay hands on them. It starts with a good history.
Like what?
Gestational age, any past medical issues, family history, asthma, chronic conditions. When did the symptoms start? Any exposures like smoke or pets? How are they feeding, sleeping? Growth, okay? Any recent travel, all that background.
Okay, then you look.
Then you observe, exactly.
Yeah.
First thing, work of breathing. How fast are they breathing?
Yeah.
Tachypnea. Are their nostrils flaring out with each breath?
Nasal flaring, a key sign.
A definite sign of air hunger, yeah.
Yeah.
Are they using extra muscles? Pulling in their skin between the ribs, that's intercostal retractions. Below the ribs, subcostal. Above the collarbones, supraclavicular.
And those retractions tell you how hard they're working.
Yes, their location and how deep they are indicate the severity of the distress. And then, is their chest and abdomen moving opposite ways? That paradoxical breathing or seesaw breathing, that's a really serious sign.
You mentioned position earlier, too, how important that is.
Absolutely vital. Their position of comfort tells you a lot. If a child insists on sitting upright, leaning forward in that classic tripod position, or kind of thrusting their jaw forward,
They're trying to open their airway.
they are actively trying to maximize airflow. They're in significant distress. Then look at their color. Skin, mucous membranes, nail beds, lips.
What are you looking for in color? Cyanosis?
Central cyanosis, that bluish tinge around the lips or tongue, is a late sign of low oxygen, usually below 85% saturation. But remember, acrocyanosis, just bluish hands and feet, is normal in newborns for up to 48 hours.
And assessing cyanosis in kids with darker skin tones can be different, right? That's important.
It absolutely is crucial to recognize those differences. In darker-skinned children, you might look for a grayish or whitish color around the mouth, on the tongue, or the mucous membranes.
Okay, not necessarily blue.
Right. Or the conjunctiva, the lining of the eyelids, might look gray or bluish instead of pink. Pallor, just looking pale, can also signal poor perfusion or anemia.
What else are you looking for physically, besides breathing effort and color?
The quality of their cough. Is it dry, barky, like a seal, productive? Are they bringing stuff up? Check their fingertips for clubbing that loss of the normal angle at the nail bed. It's a sign of chronic low oxygen, like you see in cystic fibrosis.
Okay.
Look at their chest shape, a barrel chest where the front to back diameter is equal to the side to side. That's normal until about age 2. But in an older child, it can point to chronic obstructive disease like CF or severe asthma. And always assess hydration, fast breathing, fever, not wanting to eat. They can get dehydrated really quickly.
So after looking, you listen. Auscultation.
Auscultation is key. Listen all over the chest, front, back, under the arms, mid-axillary lines. Are the breath sounds equal everywhere? Are they normal? Or are you hearing abnormal or adventitious sounds?
Like what kind of sounds?
Well, crackles, also called rails, they sound like fine crackling, often on inspiration. Think of air moving through fluid-filled alveoli, like in pneumonia.
Okay.
The source gives a good tip. They sound kind of like rolling a strand of hair between your fingers near your ear. They usually don't clear with a cough.
What else?
Snoring sounds, or ronchi. Those are lower pitched, heard throughout respiration, suggesting air moving through thick secretions in the larger airways. These might clear with a cough.
And stridor. That's a really distinctive sound, isn't it?
It is. Stridor is that high-pitched sound, usually on inspiration, signaling an upper airway obstruction. Think croup.
Got it. And wheezes.
Wheezes are high-pitched, often musical sounds, typically heard more on expiration. That's air moving through narrowed, smaller airways, the bronchioles. That's the hallmark sound of asthma.
You also sometimes tap on the chest. Percussion.
Yeah, percussion can give you clues about what's underneath. Normal lungs have a resonant sound. A flat or dull sound could mean a consolidated area like pneumonia. Timpani, like a drum, suggests trapped air, maybe a pneumothorax. Hyperresonance, a boomier sound, might be heard with asthma due to air trapping.
And feeling the chest. Palpation.
Palpation can reveal things like enlarged lymph nodes, suggesting infection, or sinus tenderness in older kids. Tactile formatus, feeling vibrations while they speak or cry, is increased with consolidation, but might be absent with trapped air or a barrel chest. Also, check pulses, compare peripheral to central. Weaker peripheral pulses can indicate severe distress and decreased perfusion.
The source makes a really important distinction between respiratory distress and respiratory failure. That sounds like something critical to get straight.
Absolutely critical to distinguish. Respiratory distress means the child is working hard, they're compensating to maintain adequate gas exchange.
So what does that look like?
You'll see tachypnea, maybe hyperpnea, deep breaths, nasal flaring, using accessory muscles, mild to moderate retractions. They might insist on sitting up. They might have a cough, or those adventitious sounds we talked about, tachycardia, maybe dusky nail beds. Their CO2 might be starting to climb, and while they're hypoxic, they can usually still speak in phrases or cry strongly.
Okay, so they're working hard but coping. When does it tip into failure?
Respiratory failure is when the body's compensatory mechanisms are breaking down, the muscles are fatiguing, the signs shift significantly.
How so?
You'll often see a change in mental status, maybe extreme irritability at first, but then progressing to lethargy. Look for circummoral cyanosis, that blue around the mouth, or mottled skin. They might start grunting with each breath or head bobbing, especially infants.
Head bobbing.
Yeah, using their neck muscles to help breathe. Their cough might become continuous, or they might stop coughing effectively. Retractions might still be moderate, but now coupled with significant accessory muscle use. And here's a really critical clinical tip. Their breathing might actually become quiet.
Quiet breathing is worse than noisy breathing. That seems counterintuitive.
It does, but it makes sense if you think about it. Quiet breathing often means they're no longer moving enough air to make noise. Airway obstruction might be worsening, or they're just too tired to generate the effort.
That's a crucial point. Quiet can be ominous.
Exactly. They might be in that tripod position, have really shallow breaths, or that seesaw paradoxical pattern. They'll have persistent low oxygen levels, even with supplemental oxygen. Their heart rate might be even higher, or eventually bradycardic, which is a very late sign. And their cry will be weak or absent. Respiratory failure means they need immediate, often advanced intervention.
What about monitoring their oxygen levels non-invasively? Pulse oximetry.
Pulse oximetry is invaluable, yeah. It measures oxygen saturation, basically, how much oxygen is attached to the hemoglobin in their blood. Normal is generally 95–100%. Anything below 90% is considered hypoxemia.
Any tips for using it?
Proper sensor placement is key finger, toe, earlobe, or for infants, sometimes the hand or foot. But be aware of things that cause bad readings. Poor circulation, lots of movement, nail polish, even severe anemia. Look at the waveform. If it's flat, the reading isn't reliable. And move the sensor site regularly to prevent skin breakdown.
And suctioning is highlighted as a critical component, especially for the little ones who can't clear their own secretions.
Oh, it's vital. Keeping those narrow airways open when they're blocked with mucus is paramount. It can be really startling for kids and parents, too.
What's the best way to do it with a bulb syringe?
The source gives a great technique tip. First, get the child secure, maybe swaddled, lay them down gently. Compress the bulb before you insert the tip into the nostril. Then release the bulb slowly to draw out secretions, remove it, and squeeze the bulb forcefully into a tissue or sink to expel the mucus.
Compress before inserting, okay?
Yeah, exactly. Saline drops can help loosen thick secretions beforehand and reassure parents the crying is okay, even helpful sometimes, as it makes the child take deeper breaths afterwards. Just make sure to rinse the syringe well.
So you've observed and assessed the child. You have a sense of their respiratory status. What tools help you pinpoint exactly what's causing the problem?
Right. That's where diagnostic tests come in. An arterial blood gas, or ABG, is kind of the gold standard for a full picture, but it's invasive.
What does it tell you?
It measures pH, the partial pressure of oxygen, PO2, and the partial pressure of carbon dioxide, PO2. It evaluates ventilation, oxygenation, and critically acid-base balance, usually reserved for critically ill kids.
Acid-base balance sounds complicated. What's a quick takeaway for respiratory issues?
The body tries hard to keep pH normal, between 7.35 and 7.45. The lungs control CO2, which acts like an acid, and the kidneys control bicarbonate, a base. A key nugget from the source for spotting a respiratory cause is this. Look at the pH and the PaSO2. If the pH is low, meaning acidic, and the PaSO2 is high, or if the pH is high, alkaline, and the PaSO2 is low. Basically, if the pH and CO2 are moving in opposite directions.
Opposite directions.
That strongly suggests the respiratory system is the primary driver of the imbalance. The kidneys might try to compensate later, but that opposite move points to the lungs. If you don't need the PaO2, a venous or capillary blood gas is less invasive and correlates pretty well for pH and PCO2.
Makes sense. What about imaging?
Imaging is essential. A chest X-ray, CXR, is often the first step. It's quick, shows structures, but uses radiation, so you always use lead shielding and are judicious about ordering them. CT scans give much more detail, a 3D picture, but use significantly more radiation. Kids often need contrast or sedation for a good CT. Ultrasound uses sound waves, so no radiation, and it's portable, which is great. MRI gives really high-quality images, super sensitive, but needs a powerful magnet, no metal, and often sedation, too.
A bronchoscopy sounds like a more involved procedure.
It is. It involves putting a scope down to directly visualize the trachea and bronchi. It's used diagnostically to collect samples or biopsies, and therapeutically, maybe most importantly, to remove inhaled foreign objects. The child needs to be NPO, nothing by mouth, for 4 to 6 hours beforehand.
Okay. What about lung function tests?
Pulmonary function tests, or PFTs, are usually for kids 5 and older. They measure lung volumes, how fast air moves out, expiratory flow rates, and lung compliance. They're great for assessing impairment, like in asthma, and seeing if therapy is working.
And the sweat test, that's specifically for cystic fibrosis, right?
Yes, the sweat chloride test is the standard diagnostic test for CF. It uses a small electrical current and medication, pilocarpine, to stimulate sweat glands, then collects the sweat on filter paper to measure the chloride level. High chloride means CF. No real prep needed, but technique is important. No touching the paper with ungloved hands.
What about identifying infections?
That's where swabs and cultures come in. Nasal or throat swabs can identify pathogens like strep or flu. Sputum cultures can too, but getting sputum from young kids is tough. You might need to do nasal or gastric washings instead. And pulse oximetry, while we use it for assessment, is also diagnostic for monitoring oxygen levels, especially when you're giving supplemental oxygen. Remember that the flow rate in liters per minute doesn't directly equal the oxygen concentration. Different devices deliver different percentages.
Okay, let's use these tools and assessment skills to look at some common issues, starting high up in the airway with infections. Otitis media, ear infections, seems like every kid gets these.
Oh, they're incredibly common, affecting about half of kids before age 2. It's basically fluid and inflammation trapped in the middle ear space.
What causes them?
Can be bacteria, strep pneumo, H. flu, M. catarrhalis, are common culprits or viruses like RSV, flu, rhinoviruses. Those short, immature eustachian tubes in kids, plus things like bottle feeding while lying flat, are big risk factors.
What are the signs you look for?
Earache, obviously. Little kids might pull at their ears, older kids might lean their head to one side. You might see a bulging red or opaque eardrum on exam. Sometimes drainage, fever, poor appetite, crying, sleep problems, sometimes even vomiting or diarrhea.
You mentioned otitis media with effusion, OME. How's that different?
OME is just fluid in the middle ear without the acute inflammation signs like pain or fever. The eardrum might look retracted, yellow or gray, and move poorly. It can cause tinnitus, a feeling of fullness, hearing loss, and even mild balance issues. For OME in an otherwise healthy child, watchful waiting for 48-72 hours is often recommended.
And swimmer's ear, otitis external.
Oh, that's inflammation of the external ear canal. The hallmark sign is tenderness when you push on the tragus, that little bump in front of the ear canal, and move with the pinna, the outer ear. Often has purulent drainage, usually bacterial, rapid onset.
How are these generally managed?
Lots of supportive care. Analgesics for pain, antipyretics for fever, keeping them hydrated, sometimes topical pain relief drops. Antibiotics are used more conservatively now, especially for OM, focusing on bacterial cases. Topical antibiotics work well for OE.
What's key for parents to know?
Caregiver education is huge. Feed infants upright, avoid tobacco smoke exposure, don't prop bottles. Discontinuing pacifier use after 6 months might help. Chronic OME can cause hearing loss, so follow-up audiology might be needed. Emphasize that immunizations like the pneumococcal, Prevnar, and annual flu shots really help reduce the incidence of OM. And if antibiotics are prescribed, stress taking the full course, storing them properly, and understanding they only work for bacterial infections. For chronic issues, tubes, myorotomy, or tympanostomy might be needed.
Okay, sinusitis is another common one that can seem like a cold that just won't quit.
Exactly. It's inflammation of the sinuses, can be viral, bacterial, or triggered by allergies. The drainage pathways get blocked.
What symptoms point towards sinusitis versus just a cold?
Facial pain or a feeling of fullness, headache, especially in older kids, maybe a low fever. The key is often cold symptoms lasting longer than 10-14 days, a persistent postnasal drip, maybe bad breath, halitosis, sometimes nausea or vomiting from swallowing drainage, thick yellow-green nasal discharge, maybe some swelling around the eyes, fatigue, irritability.
How is it managed?
Diagnosis is usually clinical based on those symptoms. Management is often supportive, but intranasal steroids can help reduce inflammation. Antihistamines or leukotriene antagonists if allergies are involved. Sometimes antibiotics if bacterial infection is strongly suspected. Saline drops or sprays and decongestants can offer some relief.
What can parents do at home?
Prevention during cold and allergy season helps. Teaching kids to blow their nose properly, one side at a time, usually around age 2. Warm compresses on the face can feel good. Using a cool mist humidifier might help thin secretions.
Nasopharyngitis and pharyngitis sounds like the common cold and a sore throat.
Pretty much. Nasopharyngitis is inflammation of the nasal passages and throat lining, the common cold. Usually viral, rhinovirus, RSV, influenza are common. Pharyngitis is inflammation focused more on the throat structures, the pharynx.
What distinguishes pharyngitis?
Look for the triad: sore throat, fever, and pharyngeal inflammation redness. Sometimes headache or abdominal pain too. It can be viral. Adenovirus is common and might come with conjunctivitis, runny nose, cough, diarrhea, or it can be bacterial, especially group A strep throat.
Strep throat sounds more serious. How does it differ?
Strep throat usually has a more painful swallow, often a higher fever. You might see white patches exudate on the tonsils and swollen lymph nodes in the neck. It spreads by respiratory droplets.
So how do you manage these?
Monitor their respiratory status, especially if very congested. Supportive care is key: rest, fluids. Hand hygiene is absolutely critical for preventing spread. Avoid touching faces, avoid sick contacts. Antibiotics are only needed if it's bacterial, like confirmed strep, and like we said before, suctioning is vital for nasal congestion in infants.
Influenza, the flu, that's a bigger concern systemically.
Definitely. It's viral, spreads easily through droplets and contact. People are contagious even a day or two before symptoms start and for up to a week after. It mainly affects the upper respiratory tract but can lead to complications.
What are the classic flu symptoms?
Usually an abrupt onset: fever, chills, headache, flushed cheeks, a cough, often dry at first, significant body aches and malaise, include symptoms like runny nose, dry, or sore throat, sometimes a rash or diarrhea in kids. Wheezing can occur if it triggers bronchitis.
How's it diagnosed and treated?
Diagnosis can be clinical, especially during flu season, but viral cultures or rapid tests from nasal or throat swabs can confirm it. Treatment is primarily supportive: rest, fluids, fever reducers, antipyretics, maybe cough suppressants if appropriate. Antivirals like oseltamivir, Namiflu, can reduce symptom duration and severity if started within 48 hours of onset. Annual vaccination starting at 6 months old is the best prevention.
The source mentioned something important about the flu vaccine and egg allergies.
Yes, a key evidence-based practice point. Current recommendations state the flu vaccine is safe even for individuals with egg allergy. It prevents significant illness, hospitalizations, and deaths each year. Parents need good information on the risks and benefits.
And the source also had some important safety tips about using over-the-counter meds for cold and flu symptoms in kids.
That's critical caregiver education. OTCs only treat symptoms, they don't cure the illness. Always use pediatric labeled medications as they've been studied for children. Read labels carefully to know the active ingredients and avoid double dosing. Children can be more sensitive, sometimes having paradoxical reactions. Critically, avoid aspirin in children and teens with chickenpox or flu-like symptoms due to the risk of Ray's syndrome. And cold medicine is generally not recommended for children under 4 years old. Acetaminophen, Tylenol, is okay for infant fever. Ibuprofen, Advil, Motrin, only for infants over 6 months.
Okay, what about tonsillitis and adenoiditis? Inflammation of the tonsils seems really common, especially in preschool and early school age.
Very common. Peak incidence around 4 to 7 years old. Tonsillitis is inflammation of the palatine tonsils, the ones you see in the back of the throat. Adenoiditis is inflammation of the pharyngeal tonsils, adenoids, located higher up behind the nose.
What causes it?
It can be viral, like flu A, Epstein-Barr virus causing mono, or bacterial, with group A strep being a major bacterial cause again.
How do you assess it?
Sore throat is the main symptom. You'll see enlarged red tonsils, maybe with white exudate, difficulty swallowing, mouth breathing, bad breath, halitosis. Enlarged adenoids can interfere with speech, making it sound nasal, cause persistent mouth breathing, snoring, and even obstructive sleep apnea. Tonsils are often graded by size, with +4 being kissing tonsils that meet in the middle.
What's the management? And surgery?
Supportive care for acute episodes. If inflammation is chronic or recurrent, causing significant problems like obstruction or repeated infections, then surgery, tonsillectomy, and possibly adenoidectomy might be considered.
Post-tonsillectomy care sounds really important, especially regarding bleeding risk.
It's critical. Positioning is key, initially side-lying or prone to allow drainage. Gentle oral assessments only. The main thing is vigilant monitoring for hemorrhage.
What's the biggest red flag for bleeding after a tonsillectomy?
This is a critical component emphasized in the source. Frequent swallowing. If a child is constantly swallowing after surgery, even if you don't see bright red blood, that is a very strong indicator of bleeding in the back of the throat.
Okay, frequent swallowing. What else?
Restlessness, tachycardia, fast heart rate, a thready pulse, pallor, looking pale, or obviously seeing frank blood. Post-op, they need to avoid coughing, using straws, or blowing their nose forcefully. Start with a soft, non-acidic diet popsicles. Ice chips are good. Manage pain adequately to minimize crying, which can increase pressure. Monitor for nausea. Dark brown blood might be old blood, but bright red blood is never normal.
What do parents absolutely need to know for home care after tonsillectomy?
Caregiver education must stress reporting any signs of bleeding immediately, as bleeding can occur even up to 10 days post-op when the scabs fall off. Avoid acidic, spicy, hard, or sharp foods for about 2 weeks. No coughing, clearing the throat forcefully, or gargling. Take pain medicine regularly, especially before trying to eat or drink to stay ahead of the pain.
Okay, let's shift to tracheitis. That sounds much scarier.
It is. Bacterial tracheitis is rare, but it can be life-threatening. It's a bacterial inflammation, often Staph aureus, of the trachea itself. It can occur after a viral URI, trauma, or intubation. A key point is that it typically doesn't improve with standard croup treatments like corticosteroids or nebulized epinephrine.
What are the signs? How does it present?
Thick, purulent tracheal secretions are characteristic. You'll often hear stridor at rest. It can be inspiratory, obstruction above vocal cords, expiratory below, or biphasic, at or below. Remember, expiratory stridor alone might also suggest a foreign body. They'll show signs of hypoxia, tachypnea, increased work of breathing with retractions. The really frightening part is the potential for rapid clinical deterioration, potentially leading to complete airway obstruction within hours, like 2 to 10 hours.
So diagnosis is partly based on that rapid decline and lack of response to croup meds.
Yes, along with the history, recent URI, trauma, intubation, and often confirmed by direct visualization via bronchoscopy or during intubation, which shows significant edema, thick secretions, and sometimes a pseudomembrane lining the trachea.
What's the immediate approach?
Close monitoring is essential continuous pulse ox, frequent reassessment. Provide oxygen if they're hypoxic. Antipyretics for fever, IV fluids for hydration. Keep the child as calm as possible, position of comfort. Allow caregiver presence. Delay any painful or anxiety-provoking procedures like IV starts or throat exams if possible. Be prepared for emergent intubation or endoscopic removal of secretions membranes. Broad-spectrum IV antibiotics are started immediately.
That sounds incredibly stressful for families.
Extremely. Providing emotional support for the family during this acute, potentially life-threatening event is a crucial nursing role.
Okay, let's switch gears to upper airway issues that aren't caused by infection, like congenital problems present at birth.
Right. Things like esophageal atresia, a EA, and tracheoesophageal fistula, TEF. These are malformations where the esophagus doesn't form completely, and there's often an abnormal connection of fistula between the esophagus and the trachea.
What are the warning signs for ETEF?
Look for respiratory distress very soon after birth, sometimes within minutes or hours. Excessive oral secretions, lots of drooling or bubbling. Cyanosis, especially during feeding attempts, and the classic 3 Cs, coughing, choking, and cyanosis with feeding. Because the esophagus might connect to the trachea, milk or formula can go straight into the lungs. You might also see abdominal distension if air is getting into the stomach via the fistula.
How is it diagnosed and managed?
Diagnosis might be suspected prenatally if there's polyhydramnios, too much amniotic fluid, on ultrasound. After birth, inability to pass a feeding tube into the stomach, along with x-rays and possibly scope procedures, confirm it. Management is geared towards surgical repair. Before surgery, maintaining airway patency with frequent suctioning of secretions is vital. Monitor respiratory status, blood gases, provide oxygen or ventilation as needed. Position them prone or with the head of the bed elevated 30 degrees to minimize aspiration risk. There'll be NPO with IV fluids.
What do parents need to know long-term?
Caregiver education focuses on preventing aspiration, proper feeding techniques post-repair, positioning, and the importance of follow-up, as these kids can sometimes have ongoing swallowing or respiratory issues.
What about laryngomalacia and tracheomalacia? That sounds like floppy airways.
That's exactly what it is. Congenital or acquired, in the case of tracheomalacia, softness or floppiness of the cartilage in the supraglottic structures above the vocal cords, or the trachea itself. This causes the airway to collapse inward, especially during inspiration.
What does that sound like?
The hallmark is inspiratory stridor, that high-pitched noise often noticed within the first couple of weeks of life, sometimes described as a crowing noise with respirations. Usually their vital signs and oxygen saturation are normal unless they're in acute distress. They might have mild tachypnea or some suprasternal retractions.
Does anything make it worse?
Yes. The stridor typically increases when the baby is lying flat, supine, crying, feeding, or stressed. It's also often associated with gastroesophageal reflux, GERD.
Does this always require intervention?
Most cases, actually no. Laryngomalacia usually resolves on its own by age 2 as the cartilage firms up. Management involves monitoring for any acute respiratory distress, worsening stridor, retractions, dyspnea, maintain airway and oxygenation if needed, monitor growth closely as feeding can sometimes be difficult, enteral feedings might be needed temporarily, or strategies like upright positioning, slow pacing, and thickened feeds for oral feeding. Antireflux medications are often used. Positioning the neck in slight hyperextension can sometimes help stent the airway open. Surgery, supraglottoplasty, is reserved for severe cases impacting breathing or feeding.
The source mentioned a case study related to this.
Yes, it highlighted an infant who'd had ETEF repair but later developed severe tracheomalacia symptoms like a barking cough and desaturations. This case showed that respiratory issues can sometimes develop later, and it also mentioned improvement with high-flow nasal cannula, showing alternative non-invasive support methods.
What should parents be taught?
Caregiver education involves teaching the signs and symptoms of baseline stridor versus worsening distress, how to monitor for feeding difficulties or choking. Using smaller, more frequent feeds can help. And importantly, reassurance that most children outgrow this by age 2.
What about subglottic stenosis? That's a narrowing lower down.
Yes, specifically a narrowing of the airway just below the vocal cords within that rigid ring of cricoid cartilage. It can be congenital or acquired, often from scar tissue after prolonged intubation.
What are the signs of subglottic stenosis?
Stridor is common. It can be inspiratory, expiratory, or biphasic, both. You might hear adventitious sounds or decreased air entry, especially after extubation if it's acquired. Increased work of breathing. A history of recurrent or difficult-to-treat croup might suggest underlying stenosis, as swelling adds to the narrowing. GERD can also irritate and worsen the inflammation.
How's it diagnosed and treated?
X-rays might suggest it, but diagnosis is confirmed by direct visualization with laryngoscopy or bronchoscopy. Management involves close monitoring, supplemental oxygen if needed, and watching for intermittently obstructive episodes. Medications like oral, IV, or inhaled steroids, or inhaled racemic epinephrine can sometimes help reduce acute swelling. For persistent or severe stenosis, surgery, like laryngotracheal reconstruction, or potentially a tracheostomy, might be necessary.
What do parents need to know if their child has this, especially if they need a track?
Caregiver education is crucial, teaching them how to monitor breathing effort and recognize signs of worsening obstruction. If a tracheostomy is placed, extensive education on tract care, suctioning techniques, especially preventing or clearing mucus plugs, and emergency procedures is required.
Okay, let's move down into the chest lower airway disorders, starting with infections.
Right. Bronchitis is basically inflammation of the larger airways, the bronchi. In young children, especially toddlers, 12-36 months, it often causes wheezing and is usually viral, with rhinovirus being a common culprit.
And bronchiolitis. That sounds similar but different.
It's inflammation of the bronchioles, the smallest airways. In the U.S., it's generally the term used for the first episode of wheezing in infants under 24 months, sometimes 12 months elsewhere. Again, overwhelmingly viral.
RSV is the big one for bronchiolitis.
Right. Respiratory syncytial virus, RSV, is the most common cause, but others like rhinovirus, human metapneumovirus, and human bocavirus also cause it. These viruses damage the cells lining the small airways. This leads to inflammation, mucus production, and cellular debris, which clog and narrow these tiny passages. Smooth muscle spasm can also contribute.
What does that do to breathing?
This obstruction traps air distally, leading to hyperinflation and potentially atelectasis, collapse of air sacs. It reduces lung compliance, stretchiness, and causes a mismatch between ventilation, air getting in, and perfusion, blood flow, leading to hypoxemia, low oxygen, and sometimes hypercapnia, high CO2. It also increases the risk for developing secondary bacterial pneumonia.
What does bronchiolitis look like when you're assessing a baby?
All that mucus and narrowing causes wheezing and crackles on auscultation. In very young or premature infants, apnea, pauses in breathing can be the primary symptom, which is scary. Usually starts like a cold. Nasal congestion, maybe a low fever, dry cough, then progresses to audible wheezing, crackles, or sometimes diminished breath sounds if air trapping is severe. Tachypnea is a key sign, often breathing faster than 60 breaths per minute. In severe cases, it can progress to significant respiratory distress and even failure.
How do you diagnose and manage it?
Diagnosis is mostly clinical, based on the age, season, and symptoms. A chest x-ray might show hyperinflation but isn't always needed. Viral testing, like PCR swabs, can identify the specific virus, like RSV. Management is primarily supportive.
What does supportive care involve?
Cardiorespiratory monitoring, heart rate, respiratory rate, oxygen saturation is crucial. Supplemental oxygen if SO2 is low, typically 90%. Ensuring adequate hydration, which might require NG tube feeding or IV fluids if they're breathing too fast to feed safely. High-flow nasal cannula or other forms of positive pressure like CPAP can help support breathing and oxygenation.
Mhm.
Good hand hygiene is essential to prevent spreading the virus. Some evidence supports nebulized hypertonic saline, salty water, to help draw fluid out of the airway walls and thin mucus. Pulmonary hygiene like chest physiotherapy, CPT, postural drainage, and suctioning can help clear secretions.
What about medications?
Routine use of bronchodilators, like albuterol, isn't generally recommended anymore unless there's a clear response. Antibiotics aren't helpful since it's viral. Corticosteroids haven't shown significant benefit. Surfactant administration has been studied in severe cases. For prevention in high-risk infants, like very premature babies or those with certain heart or lung conditions, there's palivizumab, Synagis.
Tell me more about palivizumab. It's not a vaccine.
Correct. It's a safe and effective care point to understand. Palivizumab is a humanized monoclonal antibody. It provides passive immunity against RSV, helping to prevent severe disease. It's not a vaccine that stimulates the baby's own immune system. It's expensive and requires monthly intramuscular injections throughout the RSV season, typically fall through spring, usually up to 5 doses per year. There's ongoing research into actual RSV vaccines and better treatments.
The source mentioned a critical point about using a non-rebreather mask for oxygen.
Yes, that's a crucial component for safe oxygen delivery. With a non-rebreather mask, NRB, which delivers high oxygen concentrations, you must turn the oxygen flow rate up high, usually 10 to 15 liters per minute before placing the mask on the child.
Why before?
You need to ensure the reservoir bag attached to the mask is fully inflated first. That reservoir is what allows it to deliver such high oxygen levels, around 80% or more. If you put it on with the bag flat, they might just rebreathe their own CO2. Once it's on correctly, the bag should partially deflate with each breath but stay mostly inflated.
What's the most important takeaway for parents dealing with bronchiolitis at home?
Caregiver education focuses on practical skills and knowing when to worry. Teach them how to use the bulb syringe effectively for nasal congestion. Emphasize strict hand washing and using alcohol-based hand rubs to avoid spreading RSV to others. Encourage fluids to keep secretions thin. Explain how to use nasal saline drops to loosen mucus before suctioning. Monitor temperature and use antipyretics if needed. If they qualify for palivizumab, explain the injection schedule. Avoid exposure to tobacco smoke and other pollutants.
And crucially, when should they call the doctor or seek urgent care?
Teach them the signs of worsening respiratory distress. Increased retractions, faster breathing rate, inability to feed or drink well, decreased wet diapers, sign of dehydration, lethargy, or if the child just appears significantly more ill. Especially important for high-risk infants under 1 year old. Reassure them that symptoms like cough and congestion can linger for 2-3 weeks, but they should know the red flags. Clustering care to allow periods of rest is also helpful.
Okay, moving on to pneumonia. That's inflammation deeper in the lung tissue itself.
Exactly. Inflammation of the lung parenchyma, the functional tissue, leading to consolidation areas filled with fluid or pus instead of air.
What usually causes pneumonia in kids?
Viruses are actually the most common cause, especially in younger children. Influenza and RSV are big culprits, accounting for maybe 80–85% of cases. But bacteria, like strep pneumonia, mycoplasma, a type of bacteria without a cell wall, fungi, less common and less immunocompromised, or aspiration of food, liquid, or stomach contents can also cause it.
How does the cause affect the lungs?
Viral pneumonia often causes patchy infiltrates on X-ray due to cell destruction and debris. Bacterial pneumonia more typically leads to lobar consolidation. A whole section of a lung lobe fills with fluid and inflammatory debris. Both impair gas exchange due to inflammation and potential atelectasis.
What are the assessment findings for viral versus bacterial pneumonia?
Viral pneumonia often presents with retractions to dyspnea, breathing rate 50 min, maybe a variable fever, can be low or high, cough, and often crackles or wheezing, especially common with RSV-related pneumonia. General malaise, fatigue. Older kids might complain of headaches or stomach aches. The illness duration is typically 5 to 7 days. Bacterial pneumonia often follows a recent viral URI. It tends to cause a higher fever, sometimes with chills. The cough might be productive. Breath sounds might be abnormal or decreased over the affected area. Retractions are common. Older kids might have chest pain or GI symptoms like abdominal pain or vomiting. Tachypnea, 50 min, is also typical. They often appear more ill, maybe restless due to hypoxia.
How do you differentiate and diagnose?
Pulse oximetry might show normal or decreased saturation. Chest X-ray or lung ultrasound is key to identify consolidation or infiltrates. Blood work can help. WBC count is often slightly elevated in viral, but usually much higher in bacterial pneumonia. Inflammatory markers like ESR and CRP might be elevated. Identifying the specific organism can be done with sputum culture in older kids who can cough effectively, or via nasal washing aspiration in kids under 3.
What's the management plan?
Supportive care is crucial. Supplemental oxygen if needed, ensuring adequate hydration, oral or IV, and pulmonary hygiene like chest physiotherapy, CPT, to help clear secretions. The major difference is that antibiotics are essential for bacterial pneumonia but not helpful for viral.
The source stress avoiding aspiration is part of care.
Yes, preventing aspiration is important, especially in children with swallowing difficulties or GRD, as aspiration pneumonia is a specific type. Proper positioning during feeding, thickening feeds if needed, can help. For treatment, caregiver education includes proper antibiotic administration, finish the whole course, recognizing that fatigue and cough can linger for weeks, and the importance of vaccines like the pneumococcal conjugate vaccine, PCV13 Prevnar, and palivizumab prophylaxis for RSV in relevant groups to prevent pneumonia.
And hand hygiene comes up again as critical.
Absolutely, a key clinical judgment point. Preventing the spread of respiratory pathogens through meticulous hand hygiene is paramount. Bacteria and viruses can live on surfaces for hours. Reinforce proper washing technique, warm water, antibacterial soak, lathering for at least 30 seconds, sing happy birthday twice, getting between fingers and under nails, rinsing with water flowing downwards, drying thoroughly, and using a paper towel to turn off the faucet. In healthcare settings, strict respiratory and contact precautions are essential for patients with suspected or confirmed pneumonia.
Pertussis, or whooping cough, that sounds like a very distinct illness.
It is highly contagious, caused by the bacterium Bordetella pertussis. Primarily affects unvaccinated or undervaccinated children, especially those under 10, but teens and adults with waning immunity can get it and spread it to infants. Peaks in spring and summer. Incidence has decreased dramatically thanks to the DTaP and Tdap vaccines, but outbreaks still occur.
What's a classic sign, that whoop?
Yes, the classic sign is the series of paroxysmal coughing attacks, intense, repetitive coughs that often occur in fits, frequently worse at night. The child struggles intensely to expel thick mucus. This coughing fit is often followed by the characteristic whoop sound as they forcefully inhale past a narrowed glottis, gasping for air.
That sounds exhausting.
It is. Posttussive emesis, vomiting after coughing, is very common, and the child is often left exhausted and anxious after an episode. The cough itself can persist for 8 weeks or even longer, sometimes called the 100-day cough. Between coughing fits, the child might seem relatively well.
Is the whoop always present?
Not always. A critical clinical judgment point. Very young infants, especially those under 6 months, may not have the characteristic whoop. Instead, they might just have the coughing fits, followed by apnea periods where they stop breathing or become cyanotic. This makes diagnosis trickier in the youngest, most vulnerable group.
Are there stages to the illness?
Yes, typically 3 stages. 1, the catarrhal stage, lasts 1 to 2 weeks, resembles a common cold with congestion, runny nose, rhinorrhea, watery eyes, sneezing, maybe a low-grade fever, and a mild cough. They are highly contagious during this stage. 2, the paroxysmal stage lasts 2 to 6 weeks, some things longer. This is when the classic coughing fits with the potential whoop occur. Child might look anxious before a fit, coughs repeatedly like a machine gun, eyes bulge, face might turn red or purple. Post-tussive vomiting is common, exhaustion follows. Infants might have apnea instead of the whoop. Episodes can happen frequently, maybe hourly, then plateau for weeks. 3, the convalescent stage starts after 2 weeks of paroxysms. The cough gradually lessens in severity and frequency, but can linger as a chronic cough for more than 10 weeks.
How is pertussis diagnosed and treated?
Diagnosis is often based on the clinical presentation, especially the characteristic cough and vaccine history, incomplete or absent. A nasopharyngeal swab or throat culture for Bordetella pertussis is the gold standard for diagnosis, though PCR testing is often faster. Treatment involves antibiotics like macrolides azithromycin, erythromycin, for the infected child and prophylactic antibiotics for all close household contacts, regardless of their vaccination status, to prevent spread. Supportive care includes keeping the head of the bed elevated, close respiratory monitoring, especially infants for apnea, humidified oxygen if needed, droplet precautions until they've had 5 days of antibiotics, ensuring adequate hydration, and providing rest.
The source mentions addressing vaccine misinformation here, too.
Yes, another clinical judgment point. Childhood vaccines like DTaP have drastically reduced the incidence and severity of diseases like pertussis. It's important to address parental concerns and misinformation about vaccines respectfully, explaining how different types of vaccines work, like live attenuated, inactivated, to build immunity safely.
Okay, tuberculosis, TB. Less common in U.S. kids, but still a concern globally and in certain populations.
Exactly. Caused by the bacterium Mycobacterium tuberculosis, spread through inhaled droplets from someone with active pulmonary TB. The immune system usually walls off the bacteria in the lungs, forming tubercles. It can remain dormant, latent TB, or become active disease.
How does it present differently in kids?
Diagnosis can be difficult in children because symptoms are often vague and getting a positive sputum sample is hard. Latent TB infection, LTBI, means the person is infected, has a positive skin test, TST, or blood test, IgRA, but has no symptoms and is not contagious. However, it can activate later in life. Active TB disease in children might present with a persistent cough lasting more than 3 weeks, weight loss or failure to gain weight, fatigue, persistent fever, 100.4 degrees Celsius for 2 weeks, poor appetite, night sweats. Infants might have wheezing or decreased breath sounds. Lymphadenopathy, swollen lymph nodes, is common in kids and can sometimes compress airways.
Who should be screened?
Assessment should include screening questions for children at higher risk. Close contact with someone with active TB, immigrants from high-prevalence countries, children experiencing homelessness or poverty, those incarcerated or with family members who are, immunocompromised children, and generally all children under age 5 if risk factors are present.
How is it definitively diagnosed?
Diagnosis combines clinical exam, history, and tests. A positive TST or IgRA indicates infection, latent or active. A chest X-ray showing patterns suggestive of TB, like infiltrates, often in upper lobes, nodules, cavities, atelectasis, is key. CT scans can show more detail, like a tree and bud pattern. A history of contact with an active case is very important. The gold standard is culturing Mycobacterium tuberculosis from sputum in older kids, expectorated-induced sputum or nasopharyngeal aspiration, younger kids, or early morning gastric lavage after fasting. The cultures take weeks, up to 4 weeks or more, and getting a good sample from kids is often difficult.
Treatment sounds intensive.
It is. Requires long-term drug therapy, often multiple drugs combined, especially for active TB, for several months. For example, isoniazid, rifampicin, ethimetol, pyrazinamide. Drug resistance is a growing concern, so expert consultation is often needed. Supportive care includes ensuring good nutrition and rest. Airborne precautions, negative pressure room, are needed for hospitalized patients with infectious pulmonary TB. Hydration is important.
The source mentions BCG vaccine and cultural competence.
Yes, the BCG vaccine is used in many parts of the world with high TB prevalence. It's not routinely used in the U.S. due to variable efficacy against adult pulmonary TB, but it does offer better protection against severe forms of TB in young children. Culturally, it's important to recognize that TB disproportionately affects developing nations. India, Indonesia, China, Philippines, Pakistan, Nigeria, Bangladesh mentioned. Patients and families may face stigma, discrimination, and economic hardship. The diagnostic process and treatment are long, intensive, and can be costly.
What's key for caregiver education regarding TB?
Focus on nutrition and general health promotion. Preventing exposure and spread is vital. People with active TB are usually considered non-contagious after about 2 weeks of effective treatment, but preventive medication is often given to close contacts. Discuss BCG vaccination if traveling abroad to high-risk areas. Emphasize hygiene, hand washing, covering cough sneezes. Often, directly observed therapy, DOT, is used, where a healthcare worker watches the child take their medications every day to ensure adherence, which is critical for cure and preventing resistance.
And then there's coronavirus disease, 2019, COVID-19 obviously had a huge impact.
Absolutely, caused by the novel coronavirus, SARS-CoV-2. While often milder in children compared to adults, it can still cause significant respiratory illness and affect multiple organ systems: lungs, brain, heart, kidneys, liver.
How does it affect the lungs specifically?
It attacks the alveoli, causing inflammation, increased capillary permeability, leakiness, fluid buildup, alveolar collapse, decreased gas exchange, hypoxemia, and potentially acute respiratory distress syndrome, ARDS. It can also trigger a delayed systemic inflammatory response called multisystem inflammatory syndrome in children, MISC, weeks or months after the initial infection.
How did it compare to other coronaviruses?
Coronaviruses are a family of viruses. Some cause the common cold, others croup or asthma exacerbations. SARS-CoV-2 generally caused more severe symptoms and a more prolonged course than previous epidemic coronaviruses like SARS or MERS.
How did symptoms present in kids? Were they always respiratory?
Symptoms varied widely. Many children were asymptomatic or had mild cold-like symptoms, up to half, according to the source. Common symptoms included fever, cough, congestion, fatigue, shortness of breath, muscle aches, loss of taste smell. But kids also presented with vomiting, diarrhea, or chest pain. Severe cases could lead to pneumonia, ARDS, or resemble conditions like Kawasaki disease, myocarditis, or MISC. Testing became crucial because symptoms overlapped so much with other common childhood illnesses.
The source mentions health disparities related to COVID-19.
Yes, a very important point on cultural competence. Health disparities, those avoidable differences in health risks, prevalence, severity, and access to care were starkly highlighted during the pandemic. These disparities are often linked to social, economic, and environmental disadvantages based on factors like race, ethnicity, socioeconomic status, geographic location, etc. Low-income communities and non-white populations often experience disproportionately higher rates of infection, severe disease, and death. Low socioeconomic status and living in rural areas were noted as universal factors contributing to childhood health disparities.
What were the main interventions for kids hospitalized with COVID-19?
Primarily supportive care, monitoring vital signs closely, providing supplemental oxygen, ensuring hydration, sometimes mechanical ventilation for severe respiratory failure, managing fever with antipyretics. Techniques like prone positioning, lying on the stomach, could help improve oxygenation. ECMO, extracorporeal membrane oxygenation for the most critical cases. Vaccination became available for older children, 12 plus during the source's timeframe, and adherence was encouraged. Strict infection control measures were key. Respiratory isolation, educating patients and families on hand hygiene, alcohol rubs, mask use, recommended for ages 3 plus by CDC at the time, and healthcare workers using appropriate PPE.
Were there specific treatments mentioned?
The NIH treatment guidelines cited in the source indicated that at that time there were no specific FDA-approved medications for children. Management was mainly supportive. However, some antivirals, like remdesivir, steroids like dexamethasone, and monoclonal antibodies were available under emergency use authorization, EUA, for certain high-risk children or those with severe disease.
Okay, let's move on to lower airway conditions that aren't primarily caused by infections, like respiratory distress syndrome, RDS in newborns.
Right. RDS is primarily a condition of prematurity, affecting infants born before about 34 weeks gestation whose lungs aren't fully developed yet, specifically lacking sufficient surfactant.
Surfactant, that's a substance that keeps the air sacs open.
Exactly. It reduces surface tension inside the alveoli, preventing them from collapsing completely on exhalation. Without enough functional surfactant, the alveoli collapse atelectasis, making breathing incredibly difficult and leading to poor gas exchange. There's also an inflammatory process involved. The incidence of RDS is inversely proportional to gestational age. The earlier the baby is born, the higher the risk.
What does RDS look like?
Signs of respiratory distress usually appear within minutes to hours after birth. Tachypnea, breathing rate 60 minutes, significant retractions, intercostal, subcostal, suprasternal, nasal flaring, audible grunting, trying to keep airways open, and cyanosis. On auscultation, you might hear fine crackles, rails, or diminished breath sounds. The classic chest X-ray finding is a diffuse ground glass appearance with visible air bronchograms, dark bronchial tree against the opaque lungs. In severe cases, it can look like shock with poor cardiac function and low blood pressure.
What's the connection to bronchopulmonary dysplasia, BPD?
If an infant, particularly one who had RDS, still requires supplemental oxygen by the time they reach their original due date, or 36 weeks postmenstrual age, they are often diagnosed with BPD, which is a chronic lung disease resulting from lung injury in premature infants.
How is RDS managed right after birth?
Immediate, vigorous monitoring and respiratory support are key. Pulmonary hygiene helps clear any secretions. The mainstay of treatment is providing positive airway pressure early, often starting with nasal CPAP, continuous positive airway pressure, or requiring mechanical ventilation. Administering exogenous surfactant directly into the lungs via an endotracheal tube is a critical therapy. Giving antenatal corticosteroids to the mother before preterm delivery helps mature the fetal lungs and prevent or reduce the severity of RDS. Maintaining normothermia, keeping the baby warm, is vital. Supportive care includes careful fluid and electrolyte management, nutrition, and preventing infection. The INSURE strategy, intubate, surfactant, extubate to nasal CPAP, is sometimes used. For supplemental oxygen, the principle is often less is more. Use the lowest amount needed to maintain target saturation to minimize oxygen toxicity risk.
What do parents need to understand?
Caregiver education includes teaching them the signs and symptoms of ongoing respiratory distress. If the baby goes home on oxygen, comprehensive teaching on its use and safety is needed, though home oxygen is often weaned off by 1 year. It's also crucial to provide emotional support and help parents cope with having an infant who requires intensive care like intubation.
Okay, what about acute respiratory distress syndrome, ARDS, in older infants or children? How is that different from newborn RDS?
While the outcome is similar, increased pulmonary alveolar capillary permeability leading to non-cardiogenic pulmonary edema and severe hypoxemia, the cause is different. ARDS in older children happens after a primary insult or injury to the lungs, like a severe viral infection, like flu or COVID-19, near drowning, smoke inhalation, sepsis, or major trauma. It's not due to primary surfactant deficiency, like in newborns. Respiratory failure develops within about a week of the known clinical insult and isn't primarily explained by heart failure or simple fluid overload. Chest X-ray shows new bilateral infiltrates.
How does ARDS present?
Typically with tachycardia, tachypnea, severely increased work of breathing, nasal flaring. Breath sounds might be surprisingly normal initially, or you might hear high-pitched crackles.
How is it diagnosed and managed?
Diagnosis relies on the history of a preceding insult, the clinical findings of respiratory failure meeting specific criteria like oxygenation index, and the X-ray findings. Management requires intensive care, close monitoring of respiratory status and blood gases, usually mechanical ventilation, often with specific lung protective strategies, meticulous fluid management, nutritional support, often enteral feeding, and treating the underlying cause is possible. Caregivers need reassurance, explanations about the potential need for escalating care, and understanding the process of ventilator weaning.
Congenital diaphragmatic hernia, CDH, sounds like a major structural defect.
It is. It's a birth defect where the diaphragm, the muscle separating the chest and abdomen, doesn't form completely. This allows abdominal organs like intestines, stomach, liver to migrate up into the chest cavity.
What does that do to the lungs?
It severely restricts lung growth and development in utero, leading to pulmonary hypoplasia, underdeveloped lungs, often associated with pulmonary hypertension, high blood pressure in the lung arteries, and cardiac dysfunction. It most commonly occurs on the left side. Respiratory distress is often immediate at birth or develops within the first few days.
What are the key assessment findings for CDH?
Tachypnea, nasal flaring, retractions, cyanosis, often circumoral or in nail beds. Tachycardia. Heart sounds might be shifted over to the non-affected side. Chest wall movement might be irregular or asymmetrical. Breath sounds will likely be decreased or absent on the affected side. Critically, you might hear bowel sounds in the chest cavity. The abdomen often appears sunken or scaphoid because the abdominal organs aren't where they should be.
Bowel sounds in the chest, that's a very specific sign.
It certainly is. Diagnosis might be made prenatally via ultrasound or MRI. Postnatally, the scaphoid abdomen and clinical signs confirmed by imaging like CXR, CT, or MRI make the diagnosis.
What's the immediate management?
Immediate respiratory support is crucial, often requiring intubation right after birth. Managing pulmonary hypertension is a major focus. Position the infant in semi-Fowler's position, lying on the affected side to allow maximal expansion of the unaffected lung. An NG tube is placed immediately and kept patent to decompress the stomach and bowel, preventing further lung compression. Vasopressors or inotropes might be needed for cardiac support. Careful 4V fluid management, mechanical ventilation, often high frequency, and sometimes ECMO are required before surgical repair can be attempted. Post-operative care involves monitoring for infection, respiratory distress, and managing high caloric needs due to the stress of surgery and recovery. Feeding intolerance can be an issue.
What education do parents need?
Teaching about positioning, keeping head and thorax higher than the abdomen, special feeding techniques, breastfeeding support is important, wound care after surgery, infection prevention, the importance of nutrition for growth and healing, and connecting them with support groups for families dealing with CDH.
Okay, let's talk about cystic fibrosis, EFE. This is a really complex multi-system genetic disorder.
It is. Autosomal recessive, meaning a child inherits a faulty gene, the CFTR gene, from both parents. This gene defect disrupts the function of exocrine glands throughout the body.
What does the CFTR gene normally do? And what happens in CF?
Normally, the CFTR protein helps transport chloride ions across cell membranes, which regulates the movement of water and salt. In CF, this protein is defective or missing. This leads to the production of abnormally thick, sticky mucus in various organs and also decreased secretion of pancreatic enzymes needed for digestion.
So it affects more than just the lungs.
Much more. It's a multi-system disease, often life-shortening. In the lungs, the thick mucus clogs airways, leading to chronic bacterial infections, inflammation, progressive lung damage, and eventually respiratory failure. Sinusitis is also very common. In the digestive system, the pancreatic ducts get blocked, preventing digestive enzymes, amylase, trypsin, lipase, from reaching the intestines. This causes malabsorption of fats, proteins, and carbohydrates, leading to malnutrition despite often a good appetite. The liver and other glands can also be affected by blocked ducts. Metabolically, they lose excess salt, sodium chloride, in their sweat, which can lead to hyponatremia, especially in hot weather. Most individuals with CF also experience infertility due to blocked reproductive ducts.
What are the classic signs or symptoms that might make you suspect CF?
The classic triad is often described as 1. Recurrent sinus and pulmonary infections, 2. Stautorrhea, bulky, foul-smelling, greasy stools due to fat malabsorption, and 3. Malnutrition or failure to thrive despite a good appetite. Parents might also report that their baby tastes salty when kissed.
What else might you see on assessment?
Respiratory-wise, crackles, wheezes, diminished breath sounds, prolonged expiration. Later signs of chronic hypoxia include digital clubbing and barrel chest. GI-wise, voracious appetite but poor weight gain, protruding abdomen with thin extremities, irregular bowel habits, sometimes rectal prolapse. An early sign in newborns is meconium ileus, failure to pass the first stool, meconium, within the first 24-48 hours because it's too thick and sticky. Other signs can include edema from cardiac or liver issues, distended neck veins from right heart failure, or chronic pain, headaches from hypoxia hypercarbia, sinus pain, musculoskeletal pain from accessory muscle use.
How is CF diagnosed definitively?
Newborn screening programs in all U.S. states now include testing for CF, usually by measuring immunoreactive trypsinogen IRT levels in a blood spot. If elevated, it triggers further testing, like DNA analysis for common CFTR mutations or a sweat chloride test. A diagnosis requires clinical symptoms consistent with CF plus evidence of CFTR dysfunction. This evidence can be an elevated sweat chloride level, 60 MEQL or MOL on 2 separate occasions, identifying 2 disease-causing CFTR mutations, or an abnormal nasal potential difference measurement, a specialized test. Borderline sweat tests, 3059 in infants, 4059 6-MeMo, need repeat testing or further evaluation. Chest x-rays often show hyperinflation, atelectasis infiltrates, and bronchial wall thickening over time. Pulmonary evaluation includes PFTs, typically showing decreased FVC and FEV1, increased residual volume, and respiratory cultures to identify bacteria. Lab tests like fecal elastase checks pancreatic function, and fecal fat collection can confirm malabsorption. Nutritional status is monitored via BMI and arm circumference.
The source mentions the psychosocial impact and patient-centered care.
That's incredibly important. CF is a chronic, life-shortening illness. Children and adolescents living with it can feel vulnerable, isolated, different. A multidisciplinary, patient-centered care approach is essential. It promotes shared decision-making, gives them a sense of control, and enhances self-efficacy. It helps remind them they are more than just their disease.
What are the absolute cornerstones of CF management?
Maintaining airway clearance and promoting bronchial hygiene is critical and needs to be done diligently, usually 3-4 times every single day. This isn't optional. It's essential for survival and quality of life.
What does bronchial hygiene involve?
It's a combination of techniques: effective coughing or huffing, forcing air out with an open glottis; postural drainage, using gravity by positioning the child in different ways to drain mucus from lung segments; percussion or vibration, clapping on the chest wall with cupped hands, using a mechanical percussor, or wearing a high-frequency chest compression vest, sounds like popping; avoid spine organs, done over clothing; positive expiratory pressure, PBP devices, exhaling against resistance; oscillating PEEP devices like the flutter or acapella; active cycle of breathing techniques, ACBT; autogenic drainage, and sometimes incentive spirometry for older kids.
What about medications for the lungs?
Aerosolized medications are key. Hypertonic saline helps draw water into the airways to thin mucus. Mucolytics, like Dornase alpha, pulmozyme, specifically break down DNA in thick mucus, improving lung function and reducing infection risk. Bronchodilators are often used before airway clearance to open airways. Low-flow humidified oxygen might be needed, but caution is advised as too much oxygen can potentially depress the respiratory drive in those with chronic hypoxia and CO2 retention. Nutrition support is vital. High protein, high calorie diet plus supplemental fat soluble vitamins A, D, E, K that are poorly absorbed. Enteral tube or parenteral IV nutrition might be needed. Pancreatic enzyme replacement therapy, PERT, is essential for most.
You mentioned pancreatic enzymes. How do those work?
These enzyme capsules containing amylase, lipase, trypsin must be taken with every single meal and snack to help digest food properly. Timing is crucial.
The source had a safety note about enzyme timing and antihistamines.
Yes, two critical, safe, and effective care points. First, pancreatic enzymes must be taken at the very start of a meal or snack to mix with the food effectively. They work for about 45–60 minutes. Second, antihistamines are generally contraindicated in CF because their drying effect can make the already thick mucus even harder to clear.
What else is involved in CF care?
Managing infections aggressively with antibiotics, often requiring higher doses or inhaled antibiotics due to altered drug clearance for both acute exacerbations and sometimes chronic suppression, especially against common CF pathogens like Staph aureus, H. influenza, and Pseudomonas aeruginosa. Burkholderia, Cepacia complex infections can be particularly dangerous. Short courses of anti-inflammatories might be used. GI management includes ensuring adequate fluid, fiber, and sometimes stool softeners. Routine monitoring of height, weight, lung function, FEV1, is crucial. Promoting a normal lifestyle and regular physical activity, which also helps loosen secretions, is important. Lung transplantation is an option for end-stage disease.
What are the absolute must-knows for caregiver education in CF?
They need intensive education and support. Teach the why and how of diligent bronchial hygiene, demonstrate techniques, explain the frequency, suggest pre-medicating with bronchodilators if ordered. Airway clearance should not be done right after eating. Teach how to use vests, PP devices, positioning. Stress avoiding infection exposure and reporting any increase in cough, change in sputum color amount, or fever immediately. Provide genetic counseling information for diagnosis and carrier screening for family members. Teach proper nebulizer and inhaler techniques. Reinforce the high-calorie, high-protein diet, hydration, and correct administration of vitamins and enzymes. Monitor intake and weight closely. They generally don't need salt restriction and might need salt supplements in hot weather. Address emotional and mental health needs. Connect them with resources like the Cystic Fibrosis Foundation, American Lung Association, and home health services. Ensure the whole family gets annual flu vaccines.
Okay, let's tackle asthma, another huge chronic respiratory condition in childhood.
Extremely common. It's a chronic obstructive inflammatory disorder of the airways. Key features are airway hyperresponsiveness, airways are twitchy, edema, swelling, narrowing, and increased mucus production.
What causes asthma?
It's complex, a mix of genetic predisposition and environmental factors. Can be triggered by intrinsic factors like stress or extrinsic factors, allergens. Common triggers include cold air, tobacco smoke, viral infections, a major trigger for exacerbations. Stress, pet dander, cockroaches, dust mites, molds, exercise. Status asthmaticus is a severe, life-threatening asthma attack that doesn't respond to usual treatment, leading to low oxygen, high CO2, and potential respiratory failure.
What's happening inside the airways during an asthma attack?
There's bronchospasm, smooth muscle tightens, the airway lining becomes inflamed and swollen, edematous, and glands produce excess thick mucus. There's often an immediate response, mast cells release mediators causing bronchoconstriction within 1–2 hours, and a delayed response, immune cells infiltrate, causing more inflammation, damage, edema, and mucus plugging that can recur for hours. This airway hyperresponsiveness can last for weeks or months after an exacerbation. The obstruction from muscle spasm, swelling mucus, leads to air trapping and a mismatch between ventilation and perfusion, causing hypoxemia.
What are the key assessment findings for asthma?
Cough is a big one, often non-productive initially, maybe frothy later, and characteristically worse at night. A persistent nighttime cough might be the only symptom and indicates a need for better controller therapy. Shortness of breath, dyspnea, chest pain or tightness, and wheezing, that musical sound usually on expiration, are classic. Headache can occur. You'll often see prolonged expiration on exam.
What about history and physical exam?
Ask about history of allergies. Food allergies like egg, tree nut are common comorbidities. Allergic rhinitis, hay fever, and atopic dermatitis, eczema, the atopic triad. Identify specific triggers, look for mild retractions or accessory muscle use during exacerbations. Head bobbing in infants can be a sign of increased effort. Auscultation reveals wheezing, but sometimes just coarseness or critically, a silent chest absence of breath sounds during severe obstruction, which is an ominous sign. Percussion might reveal hyperresonance due to air trapping. A barrel chest can develop with chronic severe asthma. Exposure to smoke, in utero or secondhand, worsens symptoms and lung function.
How is asthma diagnosed? Isn't it tricky in young kids?
It can be, especially under age 5 to 6 when reliable PFTs are hard to get. Diagnosis is usually based on a history of characteristic symptom patterns. Recurrent cough, wheeze, shortness of breath, chest tightness, especially worse at night or with triggers, plus a physical exam confirming signs of airflow obstruction like wheezing that is often reversible. Focused questions about symptom frequency, nighttime awakenings, activity limitation, and reliever use help assess severity. Family history, asthma, eczema, allergies is relevant. Physical signs might include atopic dermatitis, allergic shiners, dark circles under eyes, a nasal crease from rubbing, pebbled conjunctiva. During an exacerbation, tachypnea, prolonged expiration, pulse ox might be low even with seemingly mild symptoms.
Tests are used.
Chest x-ray during an exacerbation might show hyperinflation but is often normal otherwise. ABGs are usually only needed in severe attacks, show hypoxemia, later hypercapnia. PFTS spirometry, usually age 5+, are crucial. They measure forced vital capacity, FVC, and forced expiratory volume in 1 second, FEV1, often before and after giving a short-acting bronchodilator, SABA, to see if obstruction reverses. Baseline FEV1 after treatment helps track progress. A portable peak flow meter isn't diagnostic, but is useful for monitoring therapy at home, requires establishing a personal best and using zones, green, yellow, red, based on percentage of personal best to guide an action plan. Allergy testing can identify triggers. Sometimes specialized tests like bronchoprovocation, methacholine challenge, exercise challenge testing, or body plethysmography are used.
How is asthma managed? What are the goals?
Goals are to reduce impairment, minimize symptoms, maintain normal activity, and reduce risk, prevent exacerbations, loss of lung function, medication side effects. Requires a detailed respiratory assessment, wheeze location, inspiratory-expiratory ratio, overall severity control. Teaching and reinforcing correct inhaler technique is paramount using age-appropriate devices, like metered dose inhalers, MDIs, with spacers valve holding chambers, or dry powder inhalers, EPIs, and ensuring adherence. It's a team approach. Trigger identification and avoidance management is key.
What about medications? It seems complex.
The goal is good control with the least amount of medication needed, minimizing side effects, and needing rescue medication rarely. Management follows a stepwise approach based on guidelines. Like GINA, you step up therapy if control isn't achieved and step down if control is maintained for 3+ months. A calm approach during exacerbations helps. Using spacers or aero chambers with MDIs is really important for kids, gets medicine deeper into the lungs more easily.
What are the main types of asthma meds?
2 main categories: controllers taken daily to prevent symptoms, and relievers taken as needed for acute symptoms. Controllers are usually inhaled corticosteroids, ICS, the cornerstone of therapy. Long-acting beta agonists, LEBAs, are often added to ICS in moderate severe asthma, usually in a combination inhaler. Leukotriene modifiers are another controller option. Relievers are short-acting beta agonists, SABAs, like albuterol. The stepwise approach generally starts with as-needed SABA for very mild intermittent symptoms, then adds low-dose ICS, then medium-high-dose ICS plus LABA, etc., based on symptom frequency, severity, and lung function. Newer approaches emphasize using an ICS whenever a reliever is needed, for example, ICS formoterol as both controller and reliever. Phenotyping asthma, allergic, eosinophilic, helps guide treatment for severe cases with biologics.
School involvement seems important too.
Crucial. Educating school staff, teachers, nurses, coaches improves outcomes. Kids need an asthma action plan and parental consent for medication administration at school. Managing comorbidities like obesity is also important. Personalized communication is key.
What's the absolute must-know for caregiver education?
Basic facts about asthma: chronic inflammation, not just bronchospasm, the different roles of controller versus reliever meds, and skills training, inhaler use, peak flow meter. Emphasize adherence to follow-up appointments. Guided self-management is critical. Providing a written asthma action plan based on peak flow zones and SIGR symptoms, teaching self-monitoring, and reviewing the plan regularly. The plan tells them exactly which meds to take when and when to call the doctor or go to the ER. Correct inhaler spacer technique needs frequent review. Discuss obesity nutrition if relevant. Explain stepping down meds as possible after good control, usually 3 months. Stress taking controller meds every day, even when feeling well, to keep inflammation down. Avoid overuse of SABAs.
You mentioned SABA overuse. What's the safety point there?
Yes, a critical, safe, and effective care point. Rescue inhalers, SABAs, should not be needed more than twice a week, excluding pre-exercise use. If a child is using their reliever more often than that, it's a sign their asthma is not well controlled, and their controller medication or overall action plan needs to be strengthened. It indicates underlying inflammation isn't being adequately treated. Caregiver education needs to cover symptom frequency tracking as the key indicator of control and determinant of medication frequency. Technology like apps can sometimes help with adherence and monitoring.
Okay, let's round out our deep dive with a few other important conditions. Foreign body aspiration, inhaling something accidentally. Sounds terrifying.
It is, and unfortunately common, especially in the 6-month to 6-year age range, with peaks around 8-10 months when pincer grasp develops, and 1-2 years increased mobility. Boys slightly more than girls. Common culprits are small toy parts, nuts, seeds, coins, pieces of food, and latex balloons are particularly dangerous. The object can lodge in the nose, pharynx, trachea, or bronchi, often the right main bronchus due to that steeper angle.
What are the signs? Is it always obvious choking?
Initial symptoms can be coughing, choking, wheezing, stridor, gagging, possibly cyanosis. However, the initial choking episode might be unwitnessed or brief. The child might then seem fine for hours, days, or even weeks until irritation, inflammation, edema, or obstruction around the object causes symptoms like persistent cough, wheeze, stridor, or recurrent localized pneumonia.
How is it diagnosed and treated?
History is key, especially if there was a witnessed choking or coughing episode. Imaging like chest x-ray might show the object if radiopaque, or signs of air-trapping datalectasis if not, or CT scan can help. Bronchoscopy is often both diagnostic to visualize the object and therapeutic to remove it.
What's the immediate intervention?
Assess respiratory status and work of breathing immediately. Allow the child to maintain a position of comfort. Prepare for removal, which might be done at the bedside, if in upper airway, or more likely in the operating room via rigid bronchoscopy under anesthesia. After removal, observe closely for complications like laryngeal edema or respiratory distress. Antibiotics are generally only given if a secondary bacterial infection develops. Cool mist, bronchodilators, or corticosteroids might be used for 24-48 hours afterwards to reduce airway inflammation.
What's the crucial prevention message for caregivers?
Age-appropriate toys and foods are essential. Supervise young children closely during meals and playtime. Cut table food into very small, manageable pieces, e.g. grapes cut lengthwise, hot dogs cut lengthwise, and then widthwise. Teach basic choking interventions. For infants, 1 year, 5 back blows followed by 5 chest thrusts, head lower than chest. For older children, 1 year, the Heimlich maneuver, abdominal thrusts.
Apnea is another word that really worries parents. What exactly defines apnea in an infant?
It's defined as cessation of breathing for longer than 20 seconds, or a shorter pause that's accompanied by significant changes like cyanosis, bradycardia, slow heart rate, pallor, paleness, or hypotonia, decreased muscle tone.
Are there different types?
Yes. Apnea of prematurity, AOP, occurs in infants born before 34 weeks due to their immature respiratory control center in the brain. It usually resolves by the time they reach about 36 weeks post-conceptual age. The risk is inversely related to birth weight and gestational age. Apnea occurring in a term infant is considered a critical event and warrants thorough investigation to find an underlying cause like sepsis, respiratory illness, heart defects, PDA, maternal drug exposure, temperature instability, infection, low oxygen, metabolic problems, or CNS disorders. It can be due to decreased CNS drive or obstructive anatomy.
What about obstructive sleep apnea, OSA?
OSA involves partial or complete upper airway obstruction during sleep. It leads to periods of hypoventilation, hypoxia, hypercapnia, and can cause systemic hypertension. Enlarged tonsils and adenoids are a very common cause in children, but childhood obesity is an increasingly recognized factor. Craniofacial abnormalities can also contribute. Central apnea is different. It stems from a problem with the brain's respiratory center itself, the medulla, perhaps due to brain hemorrhage, meningitis, seizures, or certain muscle disorders. It's distinct from the normal periodic breathing pattern seen in many newborns.
How do you assess for apnea or OSA?
For apnea, it might be an observed cessation of breathing. For OSA, parents might report the infant startling awake, loud snoring, persistent mouth breathing, or daytime sleepiness irritability. On exam, look for signs of hypoventilation, maybe nail bed cyanosis. Assess for nasal or oral obstruction, large tonsils, tongue size. Obesity.
How's it diagnosed?
A detailed sleep history is important. Upper airway and respiratory evaluation. An apnea monitor might be used at home for high-risk infants, though its role is debated. The gold standard for diagnosing OSA is an overnight polysomnogram sleep study, which measures brain waves, oxygen levels, heart rate, breathing effort, airflow, and muscle activity during sleep. OSA is generally considered significant if there are more than 10 obstructive episodes per night or more than 1 per hour.
What are the interventions?
For apnea of prematurity or central apnea, cardiorespiratory monitoring, continuous pulse oximetry, positioning the head and neck carefully to maintain airway patency. Sometimes supportive medical therapy like caffeine, theophylline, or doxapram is used for AOP to stimulate breathing. For OSA, treatment depends on the cause. CPAP, continuous positive airway pressure, delivered via a mask during sleep is a common treatment. If enlarged tonsil adenoids are the cause, tonsillectomy and adenoidectomy, TNA, is often curative. Weight reduction if obesity is a factor. In severe cases unresponsive to other treatments, a tracheostomy might be considered.
Safe sleep practices seem critically linked here.
Absolutely. A crucial, safe, and effective care point that needs constant reinforcement. Teach and review the ABCs of safe sleep. Baby should sleep alone, on their back, in a crib, bassinet, or play yard. Share a room, but not the same bed, no co-sleeping. Use a firm mattress with only a fitted sheet. A sleep sack is okay for warmth. No pillows, blankets, bumper pads, stuffed animals, or other soft bedding in the crib. Always place baby on their back to sleep for naps and nighttime. Offering a pacifier at nap time and bedtime might reduce risk, not tethered to clothing. Review this thoroughly before hospital discharge and at every well-child visit.
What about LTE or BOUE? Those acronyms seem related to apnea.
ALT stood for Apparent Life-Threatening Event. The term has largely been replaced by BRUE, Brief Resolved Unexplained Event. It describes an episode occurring in an infant younger than 1 year, where an observer reports a sudden, brief, one-min, and now resolved episode, including one or more of the following: color change, cyanosis or pallor,
Ooh.
absent, decreased, or irregular breathing, 3, marked change in muscle tone, hyper or hypotonia, and 4, altered level of responsiveness.
So the key is that it resolved on its own.
Yes, and it remains unexplained after a basic history and physical. Diagnosis is really a process of elimination after a thorough evaluation to rule out underlying causes like GRE, infection, seizures, aspiration, heart defects, metabolic disorders, or even child abuse. Management involves careful observation, potentially cardiopulmonary monitoring, continuous pulse oximetry during evaluation, and significant emotional support for the understandably terrified family. Caregiver education would include reinforcing optimal feeding position, safe sleep practices, and potentially CPR training.
Pneumothorax, air in the wrong place.
Exactly. Air gets into the pleural space, the potential space between the lung and the chest wall. This can happen from trauma, spontaneously, especially in newborns or tall, thin adolescent boys, or as a complication of positive pressure ventilation if alveoli rupture. Hemothorax is similar, but it's blood in the pleural space.
What's a tension pneumothorax? That sounds bad.
It's a life-threatening emergency. Air enters the pleural space during inspiration, but can't escape during expiration, acting like a one-way valve. Air accumulates under pressure, collapsing the lung completely, pushing the mediastinum, heart, great vessels, trachea, to the opposite side, kinking the great veins, impairing venous return to the heart, and drastically decreasing cardiac output. It's a medical emergency requiring immediate decompression.
What are the signs of a pneumothorax?
Symptoms vary. Might be sudden stabbing chest pain, possibly radiating to the shoulder, decreased or absent breath sounds on the affected side, decreased chest wall movement on that side, maybe paradoxical breathing, tachypnea, sudden or gradual onset, retractions, flaring, grunting, decreased oxygen saturation, pallor or cyanosis, tachycardia. Hemothorax symptoms might be less obvious initially. Tension pneumothorax presents with severe respiratory distress, hypotension, distended neck veins, and tracheal deviation away from the affected side.
How's it diagnosed and treated?
Bedside ultrasound is increasingly used for rapid diagnosis. Clinical presentation is key, especially for tension pneumo. Chest X-ray confirms the diagnosis. Treatment involves supplemental oxygen. For small pneumothoraces, observation might be sufficient. For larger or symptomatic ones, or tension pneumothorax, immediate needle aspiration, needle thoracostomy, followed by chest tube placement is necessary to remove the air and allow the lung to re-expand. Continuous cardiopulmonary monitoring and pulse oximetry are essential. Caregiver education focuses on reassuring them the condition is usually temporary and managed effectively in the hospital.
Let's touch on sudden infant death syndrome, SID, and sudden unexplained death of an infant, SUID, such tragic events.
Incredibly tragic. SID specifically refers to the sudden death of an infant under 1 year of age, which remains unexplained after a thorough case investigation, including performance of a complete autopsy, examination of the death scene, and review of the clinical history. SUID is a broader term used for any sudden and unexpected death, whether explained or unexplained, occurring in infancy. Peak incidence for SIDs is between 2 and 4 months of age. Autopsy findings in SIDs might sometimes show nonspecific signs like pulmonary edema.
What are the known risk factors?
While the exact cause isn't known, a triple risk model is often discussed. 1, a vulnerable infant, perhaps due to genotype prematurity or prenatal smoke exposure. 2, a critical developmental period, peak 2 to 4 months. And 3, an external stressor like prone side sleeping, overheating, soft bedding, co-sleeping. Known risk factors include maternal age 20, low birth weight, prematurity, multiple birth, lack of breastfeeding, family history of SID, maternal smoking during pregnancy, and unsafe sleep environments. Prone side sleeping, soft bedding, co-sleeping.
What's the role of healthcare providers?
Primarily prevention through education and support if a death occurs. Guiding bereaved parents to counseling and support resources, offering empathy and support without judgment is crucial. And relentlessly educating all caregivers about safe sleep practices, ABCs, before hospital discharge and at every single pediatric visit is the most important preventive intervention we have.
Finally, the source addresses smoking and vaping among youth, a significant respiratory hazard.
Absolutely. A major public health issue. WHO stats show millions of teens using tobacco global, and secondhand smoke causes many deaths. E-cigarette use, or vaping, has exploded among high school and even middle school students, often marketed as a safer alternative to traditional cigarettes.
How do e-cigarettes work? What's actually in the vapor?
They heat a liquid often containing nicotine, flavorings, and a humectant like propylene glycol into an aerosol that's inhaled. The liquid often contains high levels of nicotine, sometimes more concentrated than cigarettes, and the actual amount isn't always clearly labeled. Flavorings are a huge appeal for youth, but some chemicals used, like diacetyl found in buttery flavors, are linked to serious irreversible lung damage, popcorn lung. The aerosol also contains humectants, like propylene glycol, linked to blood clot atherosclerosis, volatile organic compounds, and heavy metals leached from the device, like cadmium, lead, nickel, tin, which can cause inflammation, cancer, and organ damage. THC, the psychoactive component of marijuana, can also be added to vaping liquids.
Nicotine itself is a major concern, right? Especially for teens.
Highly addictive. It quickly reaches the brain, triggers neurotransmitter release, like dopamine, creating rewarding sensations and leading to physical dependence. Addiction symptoms include cravings, irritability, anxiety, restlessness, depressed mood, difficulty concentrating, frustration, insomnia, and GI issues. E-cigarette use significantly increases the likelihood that young people will eventually start smoking traditional cigarettes. There's limited evidence they are effective cessation tools for adults, and they are definitely not harmless water vapor.
The marketing seems very targeted towards youth.
Absolutely. While cigarette ads on TV radio were banned decades ago, 1971, there hasn't been the same restriction on e-cigarette advertising. Flavors like fruit, candy, mint are a huge draw for kids, unlike the flavor ban on conventional cigarettes except menthol. Marketing uses social media influencers, ads, free samples, sleek device designs that look like USB drives like JU Well, and accessories. Lack of consistent labeling regulations is also a problem. Many major e-cigarette brands are actually owned by tobacco companies.
What's the key safety message about vaping from the source?
A safe and effective care point. Despite marketing, electronic vaping devices are harmful. There's a lack of regulation and oversight of ingredients, often higher nicotine delivery than cigarettes, an increased risk of transitioning to traditional smoking, and the long-term health effects are still largely unknown. But concerning evidence is mounting about lung injury, like EVAL-I, cardiovascular effects, and potential cancer risk.
How are issues like vaping addiction addressed?
Diagnosis relies on clinical symptoms and potentially substance abuse screening, which requires building trust and ensuring confidentiality. Interventions often involve supportive care, counseling, and referral to social work or substance abuse specialists for specific help and cessation resources. Caregiver education involves supportive, empathetic listening and helping differentiate between substance abuse and addiction.
So, wrapping this all up, what does this all mean? We've really covered a lot. from the fundamental differences in a child's airway to complex chronic diseases and emergencies.
It really underscores how unique pediatric respiratory health is. Understanding those foundational differences, the narrow airway, the obligate nose breathing, the floppy cartilage, it changes how you approach everything.
And honing those assessment skills, knowing what nasal flaring, retractions, stridor, or that ominous quiet chest really signify is absolutely critical for early recognition of trouble.
Exactly. And grasping the basics of the diagnostic tools and the key interventions for common conditions like bronchiolitis, asthma, CF, or even emergencies like foreign body aspiration, based on the source material we covered today, is invaluable for providing safe and effective care.
And maybe most importantly, empowering caregivers with the right information seems like a constant theme. Teaching them the signs to watch for, proper medication techniques, safe sleep practices, the asthma action plan, when to seek help, that knowledge can truly change outcomes.
Absolutely. Thinking about how one small piece of information, like recognizing frequent swallowing after tonsillectomy as a sign of bleeding, can make a huge difference. Or understanding why a baby's airway is different shapes how urgently you respond to that stuffy nose or little wheeze.
It really highlights the interconnectedness of it all, doesn't it? How a simple viral infection can lead to bigger problems, the importance of prevention through vaccines and hand hygiene, and even how social factors impact health.
Definitely a complex but incredibly important area of pediatric care.
Keep those airways open. See you in the next one.